name's Laura Prato. I am a postdoctoral research fellow funded by the NIHR and the Alzheimer's Society, but I'm here today to talk about my work as a research assistant on the ARC National Priorities Programme, in particular the project on wellbeing in care homes. And there's a big list of people I need to thank at the beginning. So there was lots of people involved in this project. It's a cross-ARC project. It's a cross-universities project. It's been lucky enough to have the input of some fantastic people who are listed there and some absolutely brilliant expert by lived experience who've been involved all the way through. So I need to start by thanking all of these people. And again, I just need to thank Dr. Madalena Toma for letting me borrow her slides today. So for those of you who don't know much about the applied research collaborations, the NIHR funded 15 of them across the UK, and they work to support applied health and care research that responds to and meets the needs of local populations. And they work together on a number of national priority areas. And Kent, Surrey and Sussex lead on the National Priority Collaboration for Social Care and Social Work, which is where this project is based. So, the implementation priorities for adult social care, the aim and objectives of them are to support and stimulate the implementation of evidence-based service change at a national level. And there are two phases. So phase one is to identify social care activities and interventions that would benefit from evaluation and support with implementation. And phase two is to explore the facilitators and barriers to improving the evidence base and implementation by understanding how innovative methods of service work for who and in what circumstances. And out of this came this project. So its long title is the Wellbeing in Care Homes Project, the implementation of outcome-based care planning consortia. So the aim of this project was to understand care planning methods and the value of quality of life approaches within care homes. And the plan is for it to contribute to a future pilot and implementation plan, which will use the Ascot model of care planning, which I'll talk about a little bit more on one of my last slides. And the specific objectives of the study were to identify and learn from existing care planning approaches in older adult care homes and to understand the perspectives of the older adult care home sector towards quality of life, care planning and implementation. So just a quick slide about the method. So it was a qualitative project. We used semi-structured interviews, which were completed face-to-face or via remote methods. There was about 5 of us that were involved in recruitment, and we recruited in different ways. So some used local networks, some used Enrich, there was other methods, some used Facebook. We used thematic analysis, and that was applied using NVivo Collaboration Cloud, which is a piece of software that allows people at different universities to collaborate with their coding. And we coded both inductively and deductively. So originally we coded from what was coming out of the data, but then we had a number of coding workshops where we created an analysis framework which was then applied deductively to the data. And as I said earlier, experts with lived experience were involved during all stages of the project, and the ethics was granted by Kent University. So we recruited 22 professionals who were involved in conducting, managing or supporting the care planning process in adult care homes, and they were interviewed following purposive sampling. And this table gives some information about those participants. So as you can see, they were predominantly female, and they were predominantly aged 45 to 54. It wasn't a very diverse sample. Most of our participants identified themselves as being white. Most had a leadership role, and most were involved in older adult nursing and residential care homes. And so these were our key findings. So there were 4 overarching themes of what people told us about care planning in care homes and what's important. So number 1 was the value of person-centred approaches to care planning. Number 2 was the role of partnership and involvement. Number 3 was what happens after care planning. And number 4 was the need for change and improvement. So, I've lost my text. So the key thing that people told us about care planning, the most valuable thing was to make sure that it was person-centred. And most participants identified that as being understanding the person, understanding their likes and dislikes, making sure that there was activities that were suited to them, making sure that it was individualised care. However, many of our participants said that often what undermines person-centred care in practice is the content of the care planning documentation itself, which can be very focused on very prosaic aspects, so nutrition, mobility, healthcare needs, which tends to take away from being able to focus on those more person-centred approaches. It was also acknowledged that often the care planning is not reflective of what carers and residents want particularly. It's more reflective of the needs of the care home. There was also acknowledgement that sometimes some of it is due to auditing and the needs of the CQC. And that was sort of undercutting the person-centred care aspects. It was also identified that quite often staff don't receive any training. They have quite limited time. The staffing and skill mix often makes it difficult as well. And many people said that what was important was making sure that the care planning was right for the individual so that it would continue to support their independence. And again, but they said it was very difficult to individualise care. Further to that, was important when you carry out care planning, so not just when someone enters a care home, but to make sure that it's responsive and that it's responding to the needs of individuals, and if there's any changes in their condition. Another thing people told us was really important was partnership and involvement. So the involvement of residents is really important, but again, a lot of our participants acknowledge that residents are often sidelined, and that's particularly true if there's an absence of capacity, and particularly true in relation to end-of-life decisions. And a lot of that was around people didn't feel that they had the skills or had the training to talk about end-of-life, or to talk about, or to do care planning with individuals who maybe didn't have capacity because they just didn't feel confident enough to do that. There was also an acknowledgement that the involvement of families and relatives in care planning and carers is really important, but again there was an acknowledgement that often that doesn't actually happen in practice. Sometimes they said this was due to time constraints. They were also very honest in that they said that they were concerned that relatives or carers would disagree with a care plan, and so they simply didn't implement care planning with them. The care planning systems, a lot of our participants told us, are shifting towards more digital methods, and there's a hope that when they shift to those more digital methods, there'll be more involvement of carers and family and of wider health and care professionals, because it'll be easier to share that information, whereas at the minute the documents are very unwieldy, very large, and they tend to be very medically focused, and that makes it quite difficult to share and to work with families and to work with wider professionals. So what happens after care planning? So as you can see there, someone said if the care plan's read and it's done properly and people read it, it'll extend their quality of life, it'll give them a better quality of life. So most of our participants said that it's used as a guide to improve the quality of life of the resident, but they also admitted that quite a lot of the time it's not read because it's too long, or it's too medicalised, or it's too complicated. So there's improvements to be made there. And there was lots of concerns raised by different participants who were very honest, considering they were in a management role, most of them, that they feel that the limited availability of adequate time, skills, staff, training makes it very difficult for them to facilitate quality of life care planning, even though they want to, and person-centred approaches, even though there was a desire there amongst participants to be able to provide that. And again, although involving relatives and caring was desirable, they acknowledged that actually in some care homes it's happening rarely, or only when residents lack capacity. So yeah, so there's a lot to improve. And then this is what the participants themselves identified was important for change and improvement. More training around care planning for carers that work as paid carers in care homes. Having ring-fenced time available was seen as very important. Condensing some of the care planning documentation down so that they were able to focus more on person-centred care and less on kind of filling out generic risk assessments for auditing purposes. Further accessibility, so switching to that digital format so that there's more options for sharing, so that it's not a sort of giant paper block that lives in an office somewhere, but something that can be shared and that can be evolving and that other people can be involved in. So yeah, they were very positive around quality of life approaches, but that they needed some support with that. So what's the next step for this project? So this project's being extended. for another 18 months. And the plan for the next stage is to look at embedding more quality of life approaches in care planning and care homes using the Ascot care planning method. So that's a method that really focuses on quality of life approaches when you're care planning. So it has 8 domains of well-being. So there's 4 lower order needs, which are accommodation, food, safety and personal care. And there's 4 higher order needs, so social interaction, occupation, control over daily life and dignity. It's also based on a model called the circle of care, which means you can't really do care planning without involving relatives and the resident themselves, because that's part of the care planning process. It's a circle of care. And specifically for individuals who might lack capacity, there are observational periods in case somebody's not able to maybe express their preferences, so that when you're care planning, you will observe that individual on various occasions to see what they like, what they don't like, and that should involve the carer and the relatives, so that your care planning approach has more of a quality of life to it. So the plan is for a pilot to test that in one care home to see what how the care home respond to it. There's also planned for a consensus exercise with care home staff and relatives and carers to see what they identify across those different groups as the most important aspects of care planning, and also what needs to be improved on, which we can probably guess they will ask for things like training and ring fence time, but that's me guessing. But that's the next plan for sort of moving forwards and moving away from what we found to how can we embed those more quality of life approaches in care planning. And that's it. Thank you for your attention. If you've got any questions, feel free to ask me.